Thank you, Hanya, for your kind introduction. It is my great pleasure to take you through advancements in the management of cow's milk protein allergy and discuss the um, research and clinical practice. My learning objective is to describe the new evidence supporting the addition of human milk oligosaccharides as an important component of a novel hypoallergenic whey-based, extensively hydrolyzed formula for the management of cow's milk protein allergy. As a disclosure, I do receive honorarium for this presentation from Nestle Health Sciences, and I was a recipient of a research grant and serve as PI for the clinical study of hypoallergenicity of a whey-based formula with 2 HMOs. So let's set the stage by reminding you that food allergy is usually more prevalent in infants and toddlers than in older children and in adults. And the cow's milk proteins are among the most common food allergens, affecting estimated 2% of infants and young children. Fortunately, the majority of children acquire tolerance to cow's milk by age 5. However, there's a subset of those with the peak cow's milk IgE levels greater than 50 kilounits per liter that are more likely to retain cow's milk allergy until teenage years, regardless whether the cow's milk allergy is transient or persistent. It has the most significant negative impact on the nutrition and the quality of life of the affected patients as well as their families. Some of the key factors in infancy that contribute to food allergy development have been identified as low IgA levels, birth by cesarean section, exposure to antibiotics during early life, as well as underlying dysbiosis, imbalance between the Th1 and Th2 type immune responses, as well as changes in the intestinal permeability are among the most important factors. We all agree that breast milk is the gold standard for human infant nutrition. And breast milk is an incredibly immunologically active liquid. And amongst the immunologic components are HMOs, so human milk oligosaccharides, secretory immunoglobulin A, lactoferrin, lactose, as well as antimicrobial peptides and others. And these act as barriers in the gastrointestinal tract or indirectly provide immune support. So lactose, which is the second most common solid component of human milk after lipids, it appears to upregulate defenses, especially against gastrointestinal infections through antimicrobial peptides. And this effect is enhanced in the presence of butyrate, which is a short-chain fatty acid. Human milk oligosaccharides act as major substrates for bifidobacterium, and they increase levels of short-chain fatty acids, in particular butyrate. It has been long known that breastfeeding has multiple benefits, and one of those benefits is reduced infection risk. So studies have shown that infants exclusively breastfed for at least 4 to 6 months have a lower incidence of lower respiratory tract infections, also gastrointestinal infections compared to fully formula-fed infants. And this reduction in the infections among breastfed infants is thought to be related to the effects of human milk oligosaccharides that have properties that are immunomodulating and microbiome modifying. Multiple lines of evidence support the beneficial effects of human milk oligosaccharides on respiratory and gastrointestinal infections, such as reduction of viral load with the respiratory syncytial virus, increased production of short-chain fatty acids by bifidobacteria, which results in improved gut barrier function and anti-inflammatory effect, as well as serving as decoy mechanism for bacterial pathogens. So basically competing with those pathogens, and this results in reduced mucosal adhesion and invasion. And I want to show you the results of a study in which healthy infants were being fed with cow's milk-based standard formula supplemented with two HMOs, TFL and LNnT, had significantly fewer lower respiratory tract infections and requiring significantly fewer courses of antibiotics in the first year of life. So in that study, a formula containing 2 fucosyllactose and lacto-N-neotetraose was administered to healthy infants shortly after birth. It was a prospective randomized controlled multi-center interventional clinical trial of two parallel formula-fed groups. The study compared conventional formula without HMO and identical formula containing HMO. This was a study designed to evaluate growth, so it was non-inferiority study, and you can see based on the graph on the figure that the study met the primary endpoint in that formula with HMO was well tolerated and supported normal growth in healthy infants. And this was on not only weight, but it was shown through length, health circumference, and BMI z-scores that there was no significant difference between the conventional and the new formula containing HMO. As a secondary, in the secondary analysis, it was observed that infants fed a regular formula with HMOs had significantly fewer reported infections, as well as antibiotic and antipyretic use. So you can appreciate in the forest plot that particularly bronchitis, but also other lower respiratory tract infections, antibiotics, and antipyretics were used significantly less frequently in those infants fed with formula with HMO. So since infants with cow's milk protein allergy have many of the risk factors, such as dysbiosis, as well as the immune imbalance, then the next logical question was whether adding HMOs to the hypoallergenic formula is going to be beneficial to those infants. And in the first step, we had to evaluate whether this new formula actually meets the criteria for hypoallergenicity. So those criteria established by American Academy of Pediatrics state that the formula, hypoallergenic formula, has to be shown with at least 95% confidence that 90% of infants with documented cow's milk allergy will not react under double-blind placebo-controlled conditions. So we have performed an IVORY study, which is a clinical multi-center clinical trial in infants with and children with IG-mediated cow's milk protein allergy. And this compared the conventional formula and identical formula with HMOs. And in that study, we did show that based on the outcomes of the double-blind placebo-controlled challenges, that more than 90% of the infants, actually 98.4% of the infants, tolerated both conventional and novel formula with the HMO, thus confirming hypoallergenicity criteria set out by the AAP. In the subsequent step, it was evaluated whether feeding with hypoallergenic formula with two HMOs supports normal growth. And this was a cinnamon study, which is a multi-center randomized clinical trial performed in Europe. And this study met the primary endpoint. It showed that feeding with formula with HMO, which is shown as red lines, compared to the control formula showed as blue lines, that result in comparable weight gain over the study period. And similarly to the study in the healthy infants, it was observed that in the secondary analysis, there was a relative risk reduction of infections during the study. So when looking at the infants with at least one infective episodes and comparing HMO versus controls, there was a relative risk reduction. And you can see two types of analysis. The full analysis set shown in dark blue bars. The per protocol analysis shows pale blue bars. And there is a reduction, particularly on otitis media, as well as lower respiratory tract infections. But showing it in a forest plot with the odds ratios and confidence intervals, we see that there is a trend for lower respiratory tract infections, upper respiratory tract infections, and GI infections, acute diarrhea, but the confidence intervals pass cross one. Therefore, it's not significantly, not statistically significant except for the otitis media. Another way of looking at those parameters was to look at the estimated incidence rate of respiratory tract infections per month of study formula exposure based on full analysis set. And there was a reduction in the lower respiratory tract infections by 23%, which is statistically non-significant, but it was the reduction was greater at 42% for the upper respiratory tract infections for those infants fed formula with HMO with a high highly significant p-value of 0.003. Another parameter that was evaluated in cinnamon study was diversity of the microbiota, bacterial microbiota, and it was evaluated through richness and Shannon index. And a little bit surprisingly, but the infants fed with formula with HMO had lower alpha diversity, particularly at 12 months, and it's shown for both via richness and Shannon index. And it turns out that diversity by itself is not as important as the components of the diversity. And in the infants who were fed with formula with HMOs, there was delayed maturation into inclusion of the more adult type, sort of late clustered microbiota, which are shown in colors yellow, red, and purple in the graph. And if you compare the composition of the clusters, you can appreciate that the early clusters, so GC1, GC2, have more proteobacteria compared to the later clusters. They have fewer firmicutes, and most significantly, they have more actinobacteria, which contain the bifidobacteria. So not the absolute diversity, but the composition of the microbiota is a more important parameter to pay attention to. There is a further research ongoing. The platypus study taking place in Australia, which is an open label, non-randomized, single intervention, multi-center trial of amino acid-based formula with 2 HMOs, which will assess the growth and tolerance in infants with moderate to severe cow's milk protein allergy, and the results will be presented at EAACI this year. So key messages are that human milk oligosaccharides provide the important substrate for the developing gut microbiome of young infants. The Ivory study is the first clinical trial of a whey extensively hydrolyzed formula containing 2 HMOs. This formula was tolerated by more than 90% of infants and children with IgE cow's milk protein allergy, meeting the AAP criteria for hypoallergenicity. Cinnamon study demonstrated that the novel formula with 2FL and LNnT supports normal growth in infants with cow's milk protein allergy, and it was associated with significant reduction in frequency of upper respiratory tract infections by 42% in episodes per month of study formula exposure, and in a reduction in otitis media with significant difference between the HMO supplemented and control groups. And those reduction in the frequency of infections observed in cow's milk protein allergy were consistent with reduced respiratory infections among non-allergic healthy infants fed regular infant formula with HMOs, supporting, providing the evidence that adding HMO has benefits towards the strengthening of immune system and anti-infective responses. Thank you very much.